Thank you. Well, I'm presenting this because two of my colleagues that have collaborated as first author and were not able to be here today. So the context is very clear after all this information. No? Cabotegravir Rilpivirine long-acting offers a significant advance in HIV treatment, providing an alternative to oral daily medication and addressing related challenges. It has shown high efficacy, safety, and satisfaction in clinical trials and implementation studies. But few women, we have seen women, but few women have participated in Rilpivirine LA long-acting registry studies. But for me, what is more important is that we don't know really the exact characteristics of these women in the clinical trials. We don't know, we were looking when we published the article, how many older women were, and you have not disaggregate data about the women that have entered in the clinical trials. So the strongest evidence for women comes from the CARES trial that has included a lot of women, and recent, what we have been presented by Berta and by Claudia, the real-world studies. And comparative studies between women and men are very limited. When we sent our work, this publication has not been accepted, and for us it was really a surprise that has been accepted before presenting here. So Berta has told that our main finding was that Cabotegravir Rilpivirine long-acting is both effective and well tolerated among women who have complex ART histories, high burden of comorbidities, and polypharmacy. And additionally, we observed very significant differences in baseline characteristics in women compared to men. So to do something more for presenting here today, we address these issues and we conduct a comparative study with more women, more follow-up, and matching each woman with a similar men. First, we tried to do a propensity score, but the populations were so different that disappeared. We had to eliminate almost all the population. So I talked with the statistician. I said, no, it's not possible to bring only 10 women because they are similar, exactly similar to the 10 men. So our main objective was to compare biological suppression, adverse events, and durability by gender. We conduct a retrospective analysis of all patients treated at Ramon y Cajal Hospital who switched to a Cabotegravir Rilpivirine long-acting from January 2023 to January 2025. The analysis was, this retrospective analysis, but it was approved by the ethics committee. And we matched each female participant with a maximum of 4 males without replacement. The men can only enter once, considering these 5 variables. This is the most we can approach to a similar population: age, length of ART, BMI, CD4 cell counts, and country of birth. The main outcomes we considered in this analysis were virological failure, adverse events, discontinuation of ART, viral blips, whether the decision to start Cabotegravir Rilpivirine long-acting was made on patient preference or physician advice. Additionally, we assessed the time to Cabotegravir Rilpivirine withdrawal using Kaplan-Meier curves. And all this analysis has been now done with STATA. The overall population on Cabotegravir Rilpivirine was 394 participants, 49 women, and 345 men. We have to exclude, after the matching process, several women, 3 women, and much more men. 46 in the final analysis, women, 152 men, over almost 200 people. And here we have the characteristics. Of course, those with the green mark are those we use to match. So there are not big differences in these characteristics. But even, for example, when we take in account the number of people above 60 years, there are more women than men. Of course, the route of HIV acquisition was different. We have a higher proportion of AIDS in women group, and despite we match by the length of ART, the number of prior ART lines and having more than 5 lines was higher for women. And also the NNRTI experience. We study in deep the number of NRTI mutations prior to start, and we have 9% in women, 3% in men, but when we analyze, none of them confer resistance to Rilpivirine. Okay. I am doing something wrong. I don't know. Thank you. One more. Okay, this is the slide exactly. Okay, the CD4 cell count and the BMI were matched characteristics and were similar, but here we have a little bit more women with detectable viral load when we started, but really is one woman with more than 1,000 copies per milliliter, and 2 men and 2 women really with a very low viral load. Then we can talk about this. For the rest, there are a little bit more subtype A, but it's really 2 patients in main group, and the same patients were hepatitis B infected, but not actively infected. And one thing that was really very different was, even if we have already matched by age, that the number of comorbidities, dyslipidemia, psychiatric disorders, and cancer were higher in women, and also the concomitant therapies, much higher, really. And one thing that is in accordance with what the other people is presenting is who proposed to switch to Cabotegravir Rilpivirine. And in women, 70% in our cohort has been because medical proposal. Only 30% ask us to be prescribed Cabotegravir Rilpivirine, and this is the opposite in men. And the good news is that irrespective of this difference we have been talking, after a median follow-up of 15 months, transient blips, delay in injections, lost to follow-up, transfer to another center, there's no any difference. And with the main results, the withdrawal of Cabotegravir Rilpivirine was the same for men and women, even if it's due to adverse events, viral failure, or be unable to get the injections. And we have also adverse events, but there were no differences. Perhaps, as we can see in relatively cohort, we have a little bit higher percentage, and perhaps if we have more women, and perhaps we can also obtain same results and relativity. But at this point, we have no observed differences. And it's very important that the nurse or the doctor, after each visit, ask the patient, okay, you have some pain the first day, but you want to continue, and 89% and 93% in each group wanted to continue in the treatment. And this is the Kaplan-Meier curves, and the persistence after 12 or 24 months. And both men and women exhibited a high level of persistence without significant differences between the two groups. Of course, this is a retrospective study, and we have some limitation. No? The population, especially in women, is very short. The retrospective and observational nature of the study precludes definite conclusions regarding causality between gender and treatment outcomes. And to overcome these limitations, robust and objective variables were used, and the most similar population of women and men has been selected. So our main findings were, when accounting for factors such as age, origin, length of ART, BMI, and initial CD4 cell count, both women and men saw comparable rates of correct uptake, persistence, effectiveness, and safety outcomes of Cabotegravir Rilpivirine long-acting, even in the context of a greater prevalence of comorbidities and polypharmacy. In more women compared to men, Cabotegravir Rilpivirine is initiated after a doctor's suggestion. And one thing is accessory, but it is people of the women of the same age of men are faced with a greater burden of comorbidities and polypharmacy, at least in this cohort. And I want to thank. Okay, I don't know how to go. Okay, well, this is the photography of my team at Ramon y Cajal Hospital. We thank all the patients involved in this study and the infectious disease team that really are marvelous. And we all work very, very happy on these patients.